show where we dispel all of the fertility myths, share with you all of the latest and greatest information, and make sure that you are optimally prepared for your own fertility journey. So welcome back. We're happy to have you back again. We got a really interesting topic tonight. It's less related to actual infertility. It's more related to what happens to you once you're pregnant after you've had infertility. So we're just going to do a sound check. It's on, I'm pretty sure. Oh, my son's watching. Hey, Nassim, how are you, buddy? We're going to do a sound check. Hang on one second, guys. Yeah, I'm good.
On the actual receiver.
Yes.
I don't think it's on.
It's not on? No. All right, let's try it again.
Okay, you're good.
Okay. So we're just letting everybody jump on board. Welcome back to Fertility Fact or Fiction. Happy to have you all here. For those of you that haven't seen the show before, we try and cover one topic, and then we go over questions and answers. And I try and answer all of your questions live. And usually we're pretty good. We can get through almost everybody's questions, although we are growing quite rapidly. Last week was our biggest show we've ever had, so thank you to everybody that watched. And hopefully with it getting bigger and bigger, we'll just be able to answer more questions as we go. I guess at some point we might need to have it even bigger, a bigger or longer show, or maybe we're getting more people. I don't know.
More days. More days.
More days. Oh, okay. We may need to do it twice a week instead of just once a week. So welcome back, and we hope all of you are doing well and you're staying safe. To all of our patients and friends and family around the Toronto area and Peel region, I'm sorry you guys went back into lockdown. We are still open in Windsor, so thankfully things are continuing along here. But if you are in one of those other areas, please be safe, observe all of the safety precautions, and make sure that you're doing everything you can to minimize the transmission of this horrible, horrible plague that is affecting all of us. So, with that, I think we'll get started fairly shortly. So grab a coffee or a tea or something healthy like water with some fruit or vegetable in it, and join us. I think you'll find tonight's topic quite interesting. There's a lot of debate as to whether fresh embryo transfer is more successful or frozen embryo transfer is more successful, just purely in terms of getting pregnant. But the other part of the equation is what happens to the actual pregnancy. Is one version safer than the other? And so this is a brand new study, as yet unpublished, but available through Reproductive Biomedicine online as an advanced article. It will be coming out soon. And so I had a read of this just recently and thought this would be a great topic to share with you guys. We've discussed fresh versus frozen before. For those of you that haven't seen that, you can find it on our YouTube channel, www.youtube.com/Dr. Victory, Dr. Victory. Make sure you like, comment, and subscribe. It has all of our YouTube videos there, and we keep building it. And in fact, now we're starting to do some in Persian as well. And I think we're going to have that on the same YouTube channel. And so make sure you're on there and have a look around. But we've done the topic of fresh versus frozen before. It was one of our most popular videos. And we really want to bring this one to your attention as well because it adds to the mix. Capsule summary of what I've said before. In most cases, especially if your estrogen is high, frozen is better than fresh. But for patients that are doing a single embryo, or they have very low numbers of embryos, a fresh embryo transfer may actually be an entirely reasonable thing. Our place is busy, and we are actually getting a phone call, which is why you heard the bell ringing in the background at 8:03 at night. So I guess it never ends around here. People are always wanting to do stuff with us. So, okay, so I'm going to start on the topic. So this topic's quite interesting. The authors went and put together all the studies that they could to determine whether a fresh embryo transfer or a frozen embryo transfer led to different risks once you were pregnant. So this isn't about whether or not you're going to get pregnant. Like I said, we've already dealt with that before in a previous FFOF episode, but it was actually about what happens once you're pregnant. So things they were looking at were your birth weight as an infant, whether there were pregnancy-related complications like preeclampsia or abruption. They looked at whether you delivered prematurely or not. So all of these are really critical things. Now, as with all meta-analyses, which is what these authors conducted, there is always what we like to call garbage in, garbage out. So if you put in a bunch of bad studies, the information you get and the results you get are really not very valuable or useful. Whereas if you put in really strict criteria and you only select really good studies, the information that you're getting is a lot more valuable. So at the end of the day, what they did was they started with over 2,000 articles, but when they whittled it down to the essential ones that they were going to use, it was only 20 articles that met their criteria for what would be considered good reporting, good data, good evidence that they could use for the actual data analysis. So from those 20 studies, they looked at a variety of different outcomes. So the very first one they looked for was what your risk of delivering prematurely was. So keep in mind, premature is anytime before 37 weeks, but that can be as early as sort of 23, 24, and as late as 36 and a half weeks. So they don't specify whether it was very early or just slightly early, but either way, it's earlier. And certainly after you've gone through all of the trauma and the grief and the hardship and the anxiety of going through a fertility journey, the most important thing for every patient is to have a smooth sailing pregnancy where there are no complications. You're not by definition higher risk when you're an IVF pregnancy or any fertility pregnancy, but we definitely treat you a little bit differently, or at least I treat my patients a little bit differently than I do my patients who don't have fertility issues, because we want to watch them very, very carefully just to make sure that there are no glitches. So, frequently a little more observation, some more ultrasounds if necessary, a little more attention to their blood pressure, their growth patterns, and so on. So the first thing these guys looked at was preterm birth, and what they were checking was for blastocyst transfers, fresh versus frozen. So this isn't in relation to day 3 embryos or day 4 embryos. These are purely for blastocyst transfers. And what they said was that if you had a frozen embryo transfer versus a fresh embryo transfer, you had about an 11% decrease in the rate of preterm labor. Now, what does that translate into in actual numbers? Well, preterm birth affects between 15 to 20% of pregnancies. So if you reduce it by 11%, it's actually only going to be about a 2% difference in the actual rate. But if you're in that 2% and your baby is coming early, you definitely want to have your baby later, not earlier. So that's actually a substantial number. I know in actual total numbers, it doesn't sound like a lot, but it's still a meaningful number because that's still substantial, and anything we can do to reduce complications, like I said, is really important for us, and we want to do that for you. So I think that that's a very valid point. Was it significant? Yes, it was quite significant. So very good data based on thousands and thousands of events in this group, and patients in this group. So very, very important. They were comparing 42,000 patients in the frozen embryo group versus 27,000 in the fresh group. And the difference was there was only 180 events, or an average of around 100. And so in the cryopreserved group, but it was a higher percentage in the fresh group. So if you're trying to avoid preterm labor, you previously delivered preterm, you want to consider doing a frozen embryo transfer. The next thing they looked at was low birth weight. So low birth weight can come from a variety of different things, frequently high blood pressure, some vascular abnormalities in the placenta. And so they wanted to look at low birth weight as well. Now, why does it matter? If your baby's small when it's born, it's easier to deliver, people think, and not as much trauma, maybe you don't need a C-section and so on. All of those are potentially true, except that we know that babies that are very small have a higher risk of health complications later in life: diabetes, high blood pressure, heart disease, probably even things like cancer. So we want to make sure your babies are not small when they are born, because that actually has very long-term health complications and risks for your child, not when they're a child, but rather when they grow up into adults. And so avoiding a low birth weight baby is a critical issue for every OBGYN out there, let alone the fertility specialist. So very similar findings compared to the preterm babies. They showed that there was about an 18% reduction in low birth weight babies when they had a frozen embryo transfer versus a fresh embryo transfer. So again, very highly significant, important numbers. It favors doing a frozen embryo transfer versus fresh. So can you reduce preterm birth? Check. Can you reduce low birth weight? Check. The next one they looked at was small for gestational age, which is kind of a subcategory of the low birth weight. And of course, the same thing, but even more significant. This is looked at from the percentile standpoint rather than just a cutoff of weight. And when they looked at it from that percentile standpoint, they're showing a 41% reduction in the babies that have small for gestational age status. So that obviously is very, very critical as well. Again, we're avoiding these babies being smaller, and that's a really important and critical thing for you guys. So then they looked at large for gestational age. You also don't want babies that are huge because we want to protect your vagina for sure, and we want to make sure that the babies aren't at risk for diabetes. So interestingly here, while we avoid having low birth weight babies and small for gestational age babies by doing a frozen embryo transfer, we do actually slightly increase the risk or significantly increase the risk of babies being born large for gestational age. How much? A lot. It's a 68% increase in the chance that the baby is large. Which one's more risky? We don't know the long-term answer for that, although I think most people would favor having a bigger baby than a smaller baby just because the long-term consequences are more significant as far as we know. But ideally, we would find a balance. So this is an important finding, and it needs to be factored in. And then one of the other things they looked at was placental abruption. So for those of you that don't know what that is, if this is your uterus and this is your placenta, they should be stuck together, tightly opposed to one another. Sometimes, depending on what the risk factor is, it can be trauma, high blood pressure, smoking, cocaine use, a variety of different things. Sometimes just bad luck. The placenta can kind of lift away from the wall of the uterus. So if your placenta starts to lift away, all those blood vessels now can start to bleed, and that can be very risky. It frequently causes pain, heavy bleeding, and the baby decompensates and doesn't like it, and you can often end up needing to deliver the baby early. So interestingly, the patients that had fresh embryo transfers had a 42% higher rate of placental abruption than the ones that did frozen embryo transfers. Now, I gotta say, this is not something that happens very often. The total number of events from 31,000 patients was only 70 in the frozen group and 82 in the fresh group from 11,000 in that population. So, I mean, obviously a much higher rate of occurrence, but at the same time, overall, a relatively small number of people suffering from this. So take it, with a grain of salt, but remember that it is a risk factor. For those of you who have high blood pressure or, God forbid, are smoking, don't smoke if you're trying to get pregnant. It doesn't work. This is something to consider and to factor in. And then the last thing they looked at was cesarean section. And so they were looking at whether your C-section risk was higher or lower when you had a fresh or a frozen transfer. And actually, you have a higher chance of requiring a cesarean section if you had a frozen embryo transfer than if you had a fresh. And that definitely goes along with the fact that those babies do tend to be a bit bigger. So that makes sense. I mean, a larger baby is not going to fit through an average size pelvis. And certainly with a 68% increase in the number of babies that are larger, the risk is there that you're going to end up needing more room because the pelvis won't accommodate those larger babies, and so it may necessitate a C-section. So overall, on balance, which pregnancy is safer? Well, I mean, it's got to be individualized, but certainly reducing low birth weight, reducing small for gestational age, reducing preterm birth, which is huge, and then decreasing the risk of abruption. All of those are very significant factors, and they need to be included in your calculus to determine which way you want to go. I think, again, overall, when you put all of this into the equation of fresh versus frozen, If you have many eggs, many embryos, and your estrogen levels are high, it does not make sense to do a fresh embryo transfer. In particular, for those of you that have endometriosis, it makes no sense to do a fresh embryo transfer. But if your egg yield is much lower, if the number of embryos you have and are dealing with are much lower, if you are not doing pre-implantation genetic testing because you either have too few embryos, you can't afford it, or you just don't need it because you're younger, but your ovaries are a bit weaker, so you haven't made as many embryos, or maybe you're just doing it for religious, ethical reasons, then there's nothing wrong with doing a fresh embryo transfer. On balance, there are some risks and benefits, but again, keep in mind the majority of these patients going through this are not patients with just one or two embryos. These are all comers, and most of them would have several embryos, several eggs. So there are safety differences, most likely related to the concentrations of estrogen through all of these studies, and none of them have controlled for that. So again, garbage in, garbage out. You got to remember that they're not standardizing these results against average estrogen levels from the patients that they're looking at. So is it a factor of fiction that a fresh embryo transfer is safer than a frozen embryo transfer? It's a fiction. Overall balance, a frozen embryo transfer is probably safer than a fresh embryo transfer. But again, you got to individualize your care. You got to make sure that you're looking at what's important for you and your family and your health and well-being, and make your decision based on the best available information for you. So as always, like, comment, and subscribe on the YouTube channel. We're starting to really grow. We've got some videos there with 14, 15,000 views. And so we really want to bring that to your attention. Make sure you make use of that. That's what it's there for. We're hoping to kind of start a fertility university soon, where we're going to teach some classes, most likely on a Facebook platform that's coming out. And we'll keep doing these videos for you to bring attention to everyone who's going through this journey and needs help and needs information. One thing I definitely want to bring everyone's attention to is very soon we're going to be working on a fertility math, a video where we're going to go through sort of your age and your risk factors and so on, and help you calculate what your chances are. I just posted today, and hopefully some of you saw that, that many patients are simply not hearing what their doctor is saying, or maybe not listening to what their doctor is saying, or maybe the doctors are simply not communicating it effectively enough. In a population of patients in Israel that they studied, the patients were literally told that their chances were less than 5% that they would have a live birth from their next IVF cycle. And when they were asked what they thought their chances were, they said 49% instead of less than 5. So literally 10 times higher. So it's really critical that you guys understand how to do the math to figure out what your success rates are going to be, because unless you understand how we are getting to the numbers, you may walk away thinking 50% when in reality it's only 5. And I know when I talk to my patients, I always tell them, and those of you who've been with me know, that I'll say, imagine you're at the casino and they're telling you to, put down 10 or 15 or 20 or whatever $1,000 it is, and your chance of winning is X percent. So let's say it's 10%. So you need to know, would you put down the 20,000 for a 10% chance? It makes it very real and very sort of tangible for a lot of patients, because too many times you go to the fertility specialist and instead what they tell you is, well, you've got a chance, your best chance is to do IVF. Let's try that and see where we go. What they're not telling you is that chance is 5% or 10%. And in your mind, you're so invested in the process, it's very unfair to those patients, because realistically, those physicians are taking advantage of you and not explaining it to you and telling you, hey, listen, yes, you have a chance, but that chance is 5% or it's 10%. And if you're walking away from that experience thinking, well, I have a 50% chance, we have not done our job properly in explaining it to you. So make sure you know what your numbers are, make sure you know what the reality of your chances are, and we're going to do that calculus with you. So with that, always like the likes, so throw up lots of likes, guys, if those are good bits of information for you. And we're going to start taking questions. And I think I saw at least one of my kids on board. So hi, son. Hope you're doing well in Vancouver. I love you and I miss you dearly. Okay, so hello to everybody that's saying hello. Hi, Dr. Victory. This is from Facebook, Shannon. What is your opinion on embryos that stop developing after day 3? Oh, this is a great topic. I've been told different things, eggs versus sperm. Backstory, 3 retrievals with a total of 40 eggs. Wow. 18 mature, amazing. 14 fertilized. 13 day 3, 1 day 6 FET, PGT normal that resulted in a miscarriage, and 2 day 5 Morila's fresh fail. Thank you. Okay, so Shannon, first of all, I'm very sorry for that difficult journey. This is a fantastic question, and I say that because I myself have been trying to figure this out, and I've had 3 different answers from 3 different sources. So I spoke with the lab director at a very large fertility clinic in regards to a patient who had 100% fertilization. They all fertilized normally, many eggs, but none of them developed past day 4, day 5. And that lab director said 100% it was the eggs, which made no sense to me because there were lots of eggs. They were beautiful. Proven patient has previously conceived on her own. And she was actually acting as a donor for this couple. And then I spoke to my embryologist who said 100% it's the sperm, which was my thinking. And then I spoke to a colleague of mine who also said 100% the sperm, but now I'm confused as to who to believe. So we do know that the mechanism for the division of an embryo comes from the sperm in large part. And so if that mechanism is defective, they can't really divide. And if you're doing Iuis, where we inject the sperm into the egg, then you're kind of forcing the fertilization. So you're removing the sperm fertilization component, you're leaving the division component. While it could be egg quality, and we can't exclude that possibility, I personally think it's much more likely that it's the sperm if they're not dividing. So make sure that you've done a sperm DNA fragmentation test. That would be really important. There's a group out in Greece we work with called Fertilicus, and actually I just communicated with the head, I'm trying to find his name here, Dr. Pangiatos Venitus or something like that. And he and I are going to be having a Zoom call shortly because he actually has been able to isolate viruses in the actual sperm, like herpes and CMV. And he claims that you should be treating the guys that are positive for this with 2 months of antiviral medication. However, I tried to look up studies on this over the weekend and I could not find anything. So I'm waiting to do a Zoom with him to see what he says. So it could be something infectious. It could be something that's hindering the ability of the sperm to behave properly. Clearly, if the sperm is carrying viral DNA into its initial exposure to an egg, that's probably not ideal. So if there's some way to reduce that, that may be ideal. Because we produce new sperm all the time, unlike eggs, there may actually be an opportunity to intervene, reduce the amount of sperm that are affected, and then maybe improve your chances. So it's something to look at. Belinda says, happy Monday, love these videos. Happy Monday to you too, and thanks. Well, here's a good one. What's the best period cycle day to have a sauna histogram and an endometrial biopsy done? Okay, so we typically do day 7 to 12 for our sauna histograms because we want to do it before you've ovulated, and the vast majority of women will not have ovulated by day 12. And we do it after day 7 because we don't want any blood to be there where we'd be sticking it back through your tubes, because you can, if you put in enough pressure, you can push cells and debris and tissue back through the tubes and up into the uterine into the pelvic cavity, where in theory, you could actually be causing endometriosis. So day 7 to 12 makes the most sense. Some people do like a 6 to 11 or a 5 to 11 or 12. I like 7 to 12. There's no sort of magic to this or science behind it. You definitely don't want to do it after day 12 because if you're ovulating, either we could push the egg back into the pelvis and then avoid it from getting fertilized, or even worse, if it is fertilized, you can either dislodge it or cause an ectopic pregnancy. Again, in theory, that's not going to be a good idea. So that's the best plan. For endometrial biopsies, in particular, if you're trying to improve your success rate, because you think that it makes the uterus stickier, which is the theory behind doing endometrial biopsies, it should be done in the luteal phase. So most of us will do it like day 21, 23 in the cycle before you're actually doing your treatment cycle. Okay, let's check out some IG questions. And I think I answered one of the IG people earlier in the day. So all the way back to the beginning. Okay. Update on retrievals in Windsor. Yes, I have nothing to report other than that we know for sure we've submitted everything, and I emailed them today and said, please verify that we've submitted everything. I did not hear back yet, but hopefully one of them is watching and they'll let us know soon. Hi, Alana. Alana says hello. What TSH levels do you consider high for attempting pregnancy and during? So we know for sure from many, many studies, you want your TSH less than 2.5. So if you can keep your TSH under 2.5 in the first trimester, that's good. Some people will say under 3 in the first trimester and less than 2.5 in the next 2, but we just aim for 2.5 right from the get-go. So that's an easy one to answer. Would you expect the number of follicles during a stim cycle to be consistent with the antral follicle count during a natural cycle? Should I be worried that the follicles at day 4 seems lower? Thanks. Great name, by the way, our IVF roller coaster for number 2. So your antral follicle count does not necessarily reflect how many follicles will grow. In particular, antral follicle counts, depending on which study you read, have particular sizing that they should follow. The very, very small ones are not supposed to be included. So if your antral follicle count, for example, is 10, but you only get 5 or 6 growing, it may be that those were the ones for that actual wave of follicles, and that those other ones that are smaller that they did count actually aren't ready to start growing until the next wave, which might be a week or 2 apart, which is why something like duostim can often work, and that's the whole theory behind it. So should you be worried? No. If you have a reasonable number of eggs overall, it's not a problem. But if you're dealing with a lower number of eggs, worrying is never helpful during fertility treatment, but you need to at least consider your options and know what those are. So you either do another cycle if necessary, or you do something like duostim where there's back-to-back cycles. I hate it when it does that. You know when your keyboard comes up in the middle of it? I never have any idea to get rid of that. Are you still going to be doing IVF since Toronto is on lockdown? Yes, we are still doing IVF. IVF centers have not closed down. And as far as I know, there is no plan to close them down. Toronto being on lockdown does not mean that the medicine is on lockdown. So we can still help you out, no problem at all. Hello, Tripod Fertility. Tripod Fertility, my friends in Toronto have opened up. And so if any of you need expertise, help with immune-mediated infertility, by all means, let me know, and I will refer you to Dr. Romain or Dr. Zineku. They are awesome, awesome, awesome people. Honest, helpful, knowledgeable, fantastic in every way. And hopefully very soon we will all be working together in the same place. So that should be good. I hear some clinics are not allowing fresh transfers due to COVID-19. Yes. So to my knowledge, the only one doing that is One Fertility in Burlington. Don't quote me on that. I've not asked everybody, but I know that they weren't. I don't know if they've changed that since it relaxed, and they are in Hamilton. So I think they're outside of, is Hamilton part of Peel? No, it's outside of Peel. There you go. So yeah, that's still possible. What impact does stress have on the success failure of an IVF cycle? 60% reduction in success if you're stressed. That's why we have probably the best program available for stress and psychological problems in infertility. Psychologist, social worker, family doc, naturopath, addiction specialist, and an online program I pay for patients to use for free. And any of you who want it can contact us. I will allow you to use our access. Because we want to be there for you to make sure that the journey is as smooth as possible. Look, as much as I would like to say to everybody, we're going to get you all pregnant, the reality is I'd be lying to you if I told you we're going to get you all pregnant. We cannot get everybody pregnant, and we can't always use your sperm or your eggs to get you pregnant. So there are bumps in this road, and they can be big bumps, potholes, sometimes even sinkholes, unfortunately. So as a result, we need to be there for you so that when you approach those potholes, you're ready to pause, take a deep breath, look at it, and get ready to do the mental jump that you need to get over to the other side. And so we will be there with you to hold your hand through that process. But we also want to equip you with the best psychological running shoes you can get so that making that jump is easier. And that's having those resources available for you and encouraging you to use them, which I do with every single patient I speak to. So we always talk about that. This journey can be difficult. You lose control. We want to restore control to you. We know that it can be hard on you as an individual, as a couple, and it doesn't matter if you're heterosexual or same sex, it makes no difference. So or even just single. So for everybody going through this, we are very much here for you. It's my catchphrase, VRC, we're here for you. Our amazing social worker, Darcy Thachuk, said, no one walks alone at VRC. And that's another one of our catchphrases. So, we need to plaster that all over the website. No one walks alone. So yeah, no one walks alone here. We're going to hold your hand. We're going to be there to make the jump with you and make sure you use those resources. Okay. Back to Facebook. Where are the complications? What are the complications with gestational diabetes? Okay, complications with gestational diabetes, number one, are that you're at a 50% lifetime risk of developing diabetes. And number two, if you've got diabetes, you have a higher chance of developing preeclampsia, which then can lead to very serious problems, including kidney problems, stroke, kidney failure, need for early delivery, a smaller baby, and so on. And then if it's just pure gestational diabetes, those babies can be very large. So then you run into trouble with cesarean section, shoulder dystocia, where the baby's shoulder can get stuck. And honestly, babies just keep getting bigger and bigger naturally anyways. A couple of weeks ago, I had a night where none of the babies that I delivered were less than 8.5 pounds. I mean, it was crazy. And 3 of them had stuck shoulders. So that's something you want to avoid. A baby with a stuck shoulder can be a disaster for the baby's mental well-being. I mean, you can cause brain damage if they're stuck long enough. So definitely something to factor in. On top of that, other risks include risks of infection if you have a C-section, a higher risk of needing a C-section, and then the baby's risk of developing complications later in life, like high blood pressure, like diabetes, and so on. So those are all problems. Luann, whoops. Oh, I didn't mean to do that. When you're done cycle tracking and all the male testing has been done, how long is it before we hear from you about what the next step is going to be? So Luann, once you know you've done everything, at the bottom of your instruction sheet, it instructs you to call us. So that's why we always ask everybody to read the instruction sheet. So just call us and we'll go through everything with you. We set up a call to review it with you and talk to you about it. Here's a good question. Let's do that one. I'm 35, not interested in PGS. Is there a benefit to pushing embryos to day 5 or 6? Phenomenal question. So the answer to that is yes, because we know that if the embryos make it to day 5, they're likely going to have a better chance of attaching inside you, or day 6. And it selects out the ones that otherwise likely would not have made it had they not been grown out. The problem with this is there actually is no way to know whether or not an embryo will do better in you or out of you. So it needs to be individualized. And if you have only 1 or 2 embryos, it may actually be reasonable to transfer them into you on day 3. If you have a lot of embryos, it really makes more sense to wait until day 5. And if you need PGS testing because you're older or you have very weak ovaries or there's a sperm problem or whatever the case is, then for sure you need to wait till day 5. Doing PGS or PGT testing on day 3 embryos is a disaster. It actually reduces their competence and their ability to implant. And that was shown many, many years ago. So great question. I would still go to day 5 or day 6 if you're making enough embryos. If you're not, there may be some advantages to doing it earlier. And there is the theoretical possibility that the embryo would be doing better in you than it would in the lab. Remember, no matter how amazing we make the lab, and I was just reading a really cool batch of studies about sending vibrations through the incubator because it's more like being in your body where you're moving all the time, and they're suggesting that it improves success rate. So my embryologist and I are going to discuss that. it's still not the same as being in the best lab ever, which is your uterus and your pelvis and your body. So we're never going to mimic exactly what's happening physiologically in the womb, outside of the womb. So an embryo may actually have the ability to implant in you, if it's in your uterus, that wouldn't have that ability if we grew it outside. Maybe there are nutrients or fluctuations or rhythms or whatever going on inside you that we don't even know about yet, that is really critical for your embryo to develop, and we just can't provide that when we don't even know what those things are. The whole vibration thing came from the fact that several years ago there was a really interesting study, which I tried to dig up and could not find again, on which type of music was best to help embryos grow. The funny thing being that it was actually heavy metal, which I never ever would have imagined, but nevertheless, they suggested that was the best type of music, and they actually did show a statistically significant difference in the outcomes, the embryo growth and development. So when I tried looking that up, what I actually came across was people have created devices that go in the incubator that causes vibrations, and they're saying that these vibrations are mimicking kind of natural movements in your body, and that is more realistic. And actually the embryos in some of those studies did better. So interesting stuff to take a look at. Hi, doctor. Our donor is CMV positive and I am CMV negative. Could this be why all but one of our fertilized embryos died after day 5? Oh, wow. Yeah, so donor is my husband's twin. Wow. Unlikely if you're doing IVF, although according to this doctor from Fertility, it might be. So the truth is, I am looking for the answer to that exact question. This is Amy on YouTube. Amy, I don't know what the answer is. I will get back to you and answer you as soon as I know. So hopefully, Mara, if you're watching, will set up a time for me to speak with this doctor from Greece. And if he actually can point me to a study that says doing the treatment will benefit the patients, then I will happily present that to you guys. I did look it up. I could not find anything that said that doing that actually improves success rates. But who knows? Maybe there's something out there, and not every med search is going to yield the benefits or the results I need. So it's possible it's there and I'm not aware of it. So I'll let you know as soon as I know. An amazing question, though. Oh, the ever-present question. Tips for DOR, low AMH. Okay, so if you have a low AMH or diminished ovarian reserve, the reality is there are lots of things people have tried, none of which seem to actually make a difference. So there's always a study or a group that says, I did this, I did that. There's a group in Greece that swears that if they inject PRP into your ovaries, it improves the results. It's absolute gibberish. It's totally untrue. There's not a speck of evidence to support that whatsoever at all. And biologically, it doesn't even make sense. The reality is, if you're suffering from diminished ovarian reserve, you really want to maximize everything you can do per cycle. So that's lots of vitamins, healthy eating, make sure your weight's down, make sure your stress is down. Testosterone priming may work. And then I like the microdose flare protocol, but honestly, every study out there says there's no difference. DHEA may help you make more eggs. It's never been helpful for live birth. Human growth hormone may make you make more eggs. It's also never shown an improvement in live birth, although there was an older study that did and then a newer one that didn't just recently. So it doesn't look like that's really beneficial either. So all of these things can be tried, but really there is not a lot that helps. It's either keep trying, or at some point you got to draw that line in the sand and say, I'm going to consider donor. And that's different for everybody. Some people won't consider it and they'll move to adoption, and that's wonderful. There's no more noble thing a person can do. But at the same time, it's not right for everyone for adoption. It's not right for everyone for egg donation. So you have to make the decision that's right for you. And we support all of those approaches. So I never push people into anything. I'm here to support your journey. We don't have something in mind for each patient. And the one thing that's most important about what we do is money is never part of the equation. I would be much happier knowing you have made a choice that's right for you and I made nothing than you made a choice that wasn't right for you and I made an extra buck. That is not what we want here. We want to make sure that your satisfaction is 100% and it's your journey, specifically what you want for you and your family. Okay, what would I recommend as a protocol for age 36, low AMH, 0.11 nanograms, premature ovarian failure, no male factor, poor responder, and prone to early ovulation? I would do natural cycle IVF. That is the only thing you should do. Go for the one egg you make, turn it into an embryo, see what you get. I'm doing that right now with someone. She's doing 3 cycles in a row. We charge very, very little for those natural cycle IVFs. It's literally at cost. And that's the best chance you're going to get. There's no point in doing anything else. If you're having problems with the ovulation happening too early, you can try letrozole, which will actually often delay your ovulation a little bit. Dirt cheap in terms of medication costs. You just have to monitor closely. Start Cetrotide when the follicle's around 13 millimeters, maybe 14 maximum. 175 ampule dose of Manipure for 2 or 3 days. Your follicle should be ready. Trigger when it's around 18 to 20. Go get the egg. And that works quite well. I actually have done that for many patients with very, very good success rates when everything else failed. So that's the right approach, again, in my opinion. If any of my fertility colleagues are watching, we'd be happy to have your opinion. My fresh IVF baby, now 3, had normal birth weight, but it's been a struggle to get her to keep her weight steady. Could this be because she was a fresh transfer? I don't know. That's a great question. There's no data on that. Find something she likes and keep feeding her. That's the best thing. My kids was chocolate when my wife wasn't watching. Kids, don't say a word to your mother. Why should we prefer fresh eggs over frozen eggs through getting lots, or vice versa for donor eggs? If we don't have any cost burden, should we choose fresh or frozen donor eggs? That's a great question. And the answer is absolute no-brainer. And we've presented that on our show before. So it's on YouTube. Fresh donor eggs works much better than frozen donor eggs do. It is not the same success rate. No matter what anybody tells you, you are not going to get the same rates of success. You will not get the same number of embryos. You will not get the same fertilization rates. You will not get the same success rate. So it's much better getting fresh eggs and making fresh embryos. Embryos can be frozen and they do great, but eggs can be frozen, but it doesn't work as well as it does for the fresh ones. So I'm a big proponent of doing it fresh. If you can't get the eggs fresh, that's a different story. But if you can get them fresh, and there are ways to do that almost everywhere, there's no reason to use frozen. Good question. Hi, Dr. V. Endometrioma punctured and ruptured during egg retrieval. I was told there are multiple endometrioma on the left ovary. Would you suggest to move these prior to another retrieval or FET? Oh, okay. So here's the problem with endometriomas. For those of you that don't know what an endometrioma is, it's a cyst inside your ovary filled with your menstruation. So hopefully you guys can see that. I don't know if the Instagram folks can. This is your ovary, the big circle. This is the cyst inside it. As this gets bigger, it starts to put pressure. So if you get it really big where it's filling kind of a big chunk of the ovary, you start getting pressure up against the wall of the ovary. The ovary has a blood supply. And if you put pressure against parts of it, it cuts off the blood supply. Cut off the blood supply to the ovary, you're strangulating it, you reduce the egg quantity and quality. So the problem with leaving them there is that there is no question, we know for a fact that even having it there reduces your egg count. And that's now been proven in multiple studies. The problem is half the time when people go to remove these, and believe me, I've seen it even on YouTube, they butcher the ovary. And in doing so, they damage it so badly that you actually also even further reduce the ovarian function. So if you can find a really good surgeon who can deal with the endo before you do a frozen embryo transfer, for sure you should get them removed. But if it's before an IVF cycle, You should remove them if they're in the way. You definitely do not want to be puncturing endometriomas at the time of IVF. It increases the risks of infection, and those infections can be quite severe. So you definitely want to make sure that you are dealing with those if they're in the way of accessing your other eggs. If they are not in the way, you just have one endometrioma, it's not that big, it's not putting a lot of pressure on the ovary, I'd probably leave that till after the IVF cycle, because if you produce enough eggs, your estrogen level is going up. When your estrogen level goes up, it's like fuel for the endometriosis. We can never get rid of all the endo. So even if there's a little bit there, it will regrow when you're doing the IVF cycle. So it's better to do the surgery after you've done your egg retrieval than before. So again, it depends. Each patient has to be individualized, but if you've got a lot of endo there, you definitely want to focus on getting the eggs out, and you need to make sure that the endometriomas are not in the way of doing that. If you don't have a lot of endometriomas there, there's just one, I'd probably leave that alone until after the egg retrieval and then go attack it and get rid of it. And there are alternatives. You can use Lupron and Letrozole for 3 to 6 months, and that effectively almost normalizes things. So there's different ways to approach this. Make sure you find the right one for you. And for God's sakes, find a good surgeon. And most of the surgeons out there aren't necessarily experts, I'm going to choose my words carefully here, in how to deal with endo specifically as it pertains to your fertility journey. In one place I know of, routinely when they remove cysts, they start burning the hell out of the ovary with bipolar cautery because of the bleeding. 99% of the time, if you just leave the ovary alone with some Surgicel, which is something that stops bleeding, for just 10 minutes, it'll stop bleeding without you having to burn anything. They've shown, actually in the journal, it's called the Green Journal of Obstetrics and Gynecology, that if you burn the ovary, you reduce the number of eggs that are there. Well, of course you do. They're all sitting in the part you're burning. If you're burning it, you're damaging the eggs. So it's very important to be cautious with that. Okay. Second question, to confirm the day 5 embryo was complex aneuploid. Should I for sure throw out this embryo? Is it possible for it to self-correct and survive? I am struggling to discard it. This is Amy from YouTube. Amy, great question. The vast majority of people will tell you that PGT testing is very accurate, especially if you had a complex aneuploid. As long as you're prepared to terminate a pregnancy that had a complex number of abnormalities, there's no harm in putting it in. Whether or not it'll work is limited, and typically complex aneuploidies cannot correct, although there is evidence that something like a Down's embryo can self-correct by throwing out the extra chromosome. So is it possible? Yes. Is it common? No, not at all. It's not common. Destiny. I have not seen Destiny on here before. Hey, Dr. V. Endometrioma rupture. Oh, yeah, that was the same one we talked about before. Sorry, Destiny. Lindsay Duran. Very close to Lindsey Graham, the guy that's been on TV all the time. Hi, Dr. Vickery. We did 2 retrievals back-to-back and got pregnant with both fresh transfers, although we had low betas miscarriage. Oh, I'm so sorry. Is there other testing we should be looking into? I'm 37. Should we be looking into blood clotting disorders, autoimmune issues? We didn't do PGS testing. You should probably be looking into all of those. Infectious testing, PGT, potentially after 2 failed cycles with miscarriages that were recurrent, immune system testing, thrombophilia testing, sperm DNA fragmentation would be huge. Remember, guys with high sperm DNA fragmentation have a 1,183% increase in the risk of miscarriage. So make sure there's no smoking, make sure there's no drug use, make sure there's no alcohol. There is a study I'm going to report on very shortly, probably an Instagram post, showing that if you drink even around the time where you're trying to make the baby, prior to producing a pregnancy, it significantly negatively impacts your success rate. So all of these things can be really critical. Make sure your vitamin levels are appropriate. So that's really important. Oh, here's a good one. Julie, how do we choose which embryo to implant? Okay, so day 5 embryos are generally better than day 6. And then we look at the quality of the embryo in terms of its morphological score. So There's different scoring systems. Is it a grade 1, 2, 3, 4? Is it A, B, BB, BC, CC, and so on? The higher the letter grading, meaning AA, that's the very best. And depending on which embryo scoring system you're using, it gets super confusing super quickly. Some of them are better when you're a 1, and some of them are actually better when you're like a 3 or 4. So that one I don't count on as much because it depends on which scoring system the embryologist is using. But you definitely, letter grade is pretty universal, so you want AA embryos. Does that mean that the embryo is genetically normal? No, it does not mean that the embryo is genetically normal, but it's the best thing we've got when you haven't done the PGT testing. For patients trying to decide on donor eggs, what do you think of epigenetics? Will the baby get any traits from me? No, it will not. Behavior, no. Well, behavior is different. What traits can I pass on to a baby if donor eggs are used? You're not going to pass on any of your traits to the baby that are genetic, but you will pass on your traits that are related to personality things. Genetics and personality are 2 different issues completely. So keep that in mind. It's really important. Okay. Let's go through another Instagram question. Nessie says, love you too, Dad. Great kids. I am blessed with 3 wonderful kids and the world's most amazing wife. So my whole family is wonderful. Dr. B, is it normal after a failed IUI to have continuous pain? No, it is not normal at all after a failed IUI to have continuous pain. Come in and see us or your doctor. Make sure that that's being checked out. Does blood type matter for donor embryos to mom-to-be? No, not at all. Your blood type's irrelevant. Do cervical polyps need to be removed before our IVF cycle? Before egg retrieval? No. Before embryo transfer? 100%. If yes, how much of a process is it? Will it cause significant delays? It depends on your doctor. In a center where they have the access to the equipment, it's a 5-minute procedure and it shouldn't cause more than a 1-month delay. How long would you recommend to continue treatment with IUI after a LEAP procedure? Jasmine, I'm not sure I understand the question. I would wait at least 3 months after a LEAP procedure before starting IUI, if that's what you mean. My dad is my hero. That's a great title. Why did my kids not put that in there? After cycle tracking is complete and male testing is done. Oh, we already talked about that one. Okay. So that's just contact the office and we will talk to you. Do I need to complete 3 failed IUIs before getting on a funded IVF list with you in Toronto? Lexi, yes, we do ask patients to do 3 IUI cycles before jumping on the funded wait list. We just think that's important because many will succeed. So it's important to do that. We're very close to seeing if our IUI worked. Congratulations. Just want to thank your amazing team for the care and checking in with us all the time. Lisa is awesome. Thank you for saying that. Lisa is awesome, as are all of our team. And thank you, team. I love you guys. You're amazing. Is Lupron always needed before an FET? Having some anxiety about shutting down again and being stuck in menopause. So you will not be stuck in menopause for very long at all because we put you on estrogen. And before an FET, we're using 1 month Lupron normally, so it won't last more than 1 month. So that should be perfectly fine. If you're using the 3-month kind, you can always use the pill to not have to go through the menopausal side effects. So keep that in mind as well. Does December holiday affect clinic hours or potential retrieval if the clinic opens soon? We will not be open over Christmas. No one's staying open over Christmas. So everybody's closing down because all of us have been killing ourselves all year long. Cushing syndrome and PCOS together, please advise. Ranpreet, sorry, you need to call me. That is not or Taranpreet, sorry. Taranpreet, you need to call or get a consult. That's a complex condition and requires very, very close management because you need steroids for your Cushing to manage that, and then you need to manage the PCO. So make sure that is being dealt with by an endocrinologist or an REI. It's not really the kind of thing we would deal with here. What about PRP before FET 48 hours prior? Not a single study has shown anything on 48 hours prior. There are studies that I'm aware of anyways. There are studies that have looked at PRP to thicken the lining. I'm trying it right now in one patient. It's made a smidgen of a difference. I don't know that it's going to make all the difference. There are some studies that have shown benefit though. Do you prescribe Pregvit prenatals to your patients? Yes, I do. We just reviewed last week. Watch last week's show with Jen Strong, our naturopathic doctor. We reviewed all the vitamins. It was a great one. It's been 21 years. I haven't said anything. That's messy. For patients with frozen PGS embryos, what advice do you give about transferring now during COVID? No. So today, there was a study released demonstrating that there is no miscarriage increase in patients who are going through trying to attempt pregnancy at this time with COVID. So even those who get COVID. So you can go ahead and try and get pregnant, guys. There's no risk. LOL, your son just commented and I literally laughed out loud. That's so cute. They watch my episodes. My kids do watch my episodes. Not my daughter. She's in Scotland, so she better be asleep. Oh, honey, she's watching. Messy. Okay, now my family's communicating to one another live on the show. Kellyanne from Facebook. Dr. Victory guided me wonderfully through a very hectic gallbladder attack-filled, exhausting, and painful high-risk pregnancy during a global pandemic. He even calmly and sweetly talked me through a full-out anxiety attack during my emergency C-section. I made it through to the other side with my gorgeous baby boy because of him. He is the best. Thanks, Dr. V. Thank you. That's very sweet to hear. I hope Junior is doing well. What are your thoughts on GV eggs at retrieval? Can the number of, that's germinal vesicle, very immature, be reduced with a high HCG trigger? No. So your GV follicle needs to grow in order to get out of its GV stage. A high HCG trigger will not help that. So you may need to go longer, and that would probably be the appropriate step there, not a high HCG trigger. And please be careful with a high HCG trigger because that's an OHSS risk. The endometrioma allowed me to only get 7 eggs today. Destiny, I'm sorry about that. I would probably remove them if they're having trouble getting at your other endometrial, your other eggs. If I would like to do my second IVF around middle of next year, when should I ask my family doctor to do the referral? Now we can get everything ready. Okay, a couple of last questions, guys. How often is a day 5 AA embryo complex aneuploid for a person under 35? I don't know specifically about a grade AA embryo, although actually a lot of the best looking embryos are not genetically normal. Having said that, under 35, it should only be around 50% if you're right around 35. If you're below 30, it should be less than 30. If you're around 25, it should be less than 25. So those are kind of the numbers we look at. What's my view on back-to-back cycles? So DuoStim has proven benefit, and there is some evidence that back-to-back cycles yields more eggs, probably like the DuoStim effect. So actually, I'm a believer. I think it works. Do I advise both men and women to give up alcohol during stim cycles? I advise men and women to give up alcohol, period. Alcohol is a class 1 carcinogen known to cause 7 types of cancer and suspected to cause 4 more. Never touched it in my life, never will. Don't drink, it's terrible for you. We use alcohol to kill biological tissue in the lab. Why would you put that inside you? It literally is used to kill embryos, viruses, bacteria. What do you think's in hand sanitizer? You're literally drinking hand sanitizer, guys. So don't do that. Okay, it is 8:59 and I'll probably get signed off of Instagram in a minute. So last question, super quick. What is the wait time to start on the IUI process? There is no wait time. We can start anytime. Any other questions you have, don't hesitate to send to us. Comment on YouTube. Make sure you subscribe to our YouTube channel. We always enjoy doing these shows. We will be back again. We had an amazing time in Toronto interviewing people on the street. Watch for that video. It'll be up soon. So you guys take care. Have a great night, and we'll look forward to seeing you again next week. Bye.